Good afternoon and welcome to the OR Today webinar series. We're excited to have over 200 registered attendees for today's webinar. Just a quick reminder to save the date for our 5th annual OR Today Live Surgical Conference 2019, which will take place on August 18 to 20 in Las Vegas. Join us to discover new opportunities, broaden your knowledge and exchange ideas. Visit ortodaylive.com for more information. Okay, let's kick off today's webinar by giving an OR Today Live surprise pack to the attendee that can tell me the answer to the following trivia question. Today's sponsor, Encompass, is headquartered in Georgia. Name the Georgian author who wrote Gone with the Wind. While you're answering, I want to remind you today's webinar is eligible for 1 continuing education hour. To obtain your certificate, you must complete the post-webinar survey, which will appear immediately on your computer screen at the end of today's call. 1 lucky attendee will have the opportunity to win an Amazon gift card, courtesy of OR Today, just for completing the survey. Okay, and let's see who the winner of our OR Today Live Surprise Pack is. And it is, let's have a look, Pat Horn-Surferer. I hope I've got your name correct, Pat. Congratulations. The correct answer is Margaret Mitchell. OR Today would like to thank our sponsor, Encompass. Encompass Group is one of the leading manufacturers and marketers of reusable textiles, professional apparel, disposable and single-use medical products. Encompass Group believes that every patient, resident, caregiver and family member should feel safe and comfortable in today's healthcare environment. Markets served include acute care, long-term care, senior care, retail healthcare apparel, hospitality and government operations. For more information, visit encompassgroup.net. Our presenter today is Angie O'Connor, Director of Clinical Resources at the Encompass Group. Angie, you may begin whenever you're ready.
Thank you, Linda, so much for the warm welcome. I appreciate the opportunity today to present this webinar, Start Warm, Stay Warm, Every Minute Counts. Just a little bit about the presentation and myself. I'm actually a former peri-op nurse, and so I want to share some information with you today that's documented, it's evidence-based, as well as sharing some of my observations as I consult now in the OR environment. And hopefully some of these insights will help us to take a deeper look, if you will, at keeping our patients warm. So with that said, let's go ahead and get started. Kelly Putnam was the author of the AORN First Look Peri-op Briefing, and this briefing was done for the update of the guideline for prevention of unplanned patient hypothermia back in 2015. And in the briefing, Kelly stated that the new guideline does not recommend one method over the other. So I think at this point, the guideline has been out for just a bit, and we all probably have that same question though. You know, without a recommendation that's clear-cut for us, what are we to do with our patients? My goal today is to really provide you with information that will encourage you to collaborate with your teammates. And this includes your pre-op folks, the intra-op folks, and PACU, in addition to anesthesia and surgeons. You really want to talk about what is the best method for your patient population, method or combination of methods, and then how do you all work together with that common goal to maintain normal thermia throughout the process. You can see in our learner objectives that we'll be talking about the outpatient surgical population and how patient warming ties into that environment now. We'll talk about the continuing prevalence of hypothermia. We'll look at the role of enhanced recovery after surgery and patient warming. And then we want to, again, really develop the role of the peri-op team in maintaining normal thermia. We'll talk about cutaneous heat loss and the rule of 9s. And then we'll also review typical warming methods. And then lastly, talk about ways that we can combine active and passive measures to really achieve the optimal outcomes that we're looking for. So as I prepared for this webinar, I read a number of articles related to patient warming, and I went back quite a few years. This slide represents 2 articles, one from 2006 and the other from 2017. And what I realized as I read various articles, the language is very similar. I have to say that the newer articles, we're fortunate to have a lot of data that we can provide in the articles. Gives us some historical perspective on what's happened and how we're performing now. Well, what I found is that a lot of the messaging was really similar. So in the 2006 article, you can see the quote that they listed here, that peri-op nurses can help prevent unplanned hypothermia by enacting, supporting, and formalizing policy in the perioperative arena. And so in my mind, that says that all of us in the peri-op area really need to be proactive and responsible for this and work together to have a policy for our area to prevent hypothermia. Well, then you flash forward to 2017 to this great article, and it says in this article that up to 70% of surgical patients experience inadvertent hypothermia, and then generally defined as a core body temp less than 36 degrees. So in spite of all of our efforts with SCIP-I and F10 and really a lot of focus on preventing hypothermia over the last many years, we see that our patients are still experiencing hypothermia, and we have a lot of risk involved. So what are we missing in this process? So hopefully we can develop that thought as we move through this webinar. So I'm going to talk just a little bit about the ASCs and outpatient surgery environment, and I want to really review this and discuss it, because as we all know, our procedures are shifting to this environment, and preventing hypothermia is a really big element here as well. So you can see on this timeline, this is ASPAN's historical timeline, and the first ambulatory surgery program started back in 1961 in Grand Rapids, Michigan. Then fast forward 45 years later, and in 2006, the number of outpatient procedures exceeded inpatient for the first time, and as we all know, that number continues to increase. I read a great article in the AORN Journal. It was the June issue, and it was a peri-op briefing that was done by Jennifer Butterfield, and she really gave an excellent overview of the ASC environment. And in that article, an estimated 57% of outpatient surgeries were performed in ASCs in 2015, and it's also projected that it will increase to 60% by 2020. The patients that still have multiple comorbidities and require more complex procedures and also more complex resources for their hospitalization, those folks will remain in the inpatient facilities. But what we're seeing is this shift to the ASC is really providing us with a population that is often healthier, and it makes that environment ideal to really manage the services that are provided there, and also provides an opportunity to eliminate unnecessary waste and spending. So when we look at those types of attributes, this is great for our patients. It's great news for surgeons. They love to work in an environment like that. And also the insurers are interested in the ambulatory market because of all of those benefits. Today's ASCs can perform more than 3,500 Medicare approved procedures, and as we know, they all continue to increase in complexity. So how does warming tie into all of this? Well, many of you may be familiar with the ASC Quality Reporting Program. It was launched in 2012 by CMS, and it began to affect the 2014 calendar year payments. In this reporting requirement, for those that do not meet that requirement, and that includes allowing their data to be publicly available, they may incur up to a 2 percentage point reduction in any payment update for that year. So we can see that they've put some teeth in this requirement. They really want us to report, and there are financial benefits or penalties depending on how you respond to that. So this ties into patient warming because in 2017 they added additional measures, including the ASC 13 normothermia outcome measure. This data was started, the collection process was started in January of 2018 for ASC 13, and it will impact payment year 2020. So similar to the previous SCIP INF 10 reporting requirement that we had, this measure assesses the percentage of patients who are normothermic within 15 minutes of their arrival to the PACU. And it's limited, though. It does have some limitations. It's for patients who have either general or neuraxial anesthesia, and it's for procedures that are of 60 minutes in duration or greater. So I say there's some limitations to this because those shorter procedures, as we're going to talk about throughout this presentation, still have a lot of the same exposures leading up to their anesthesia induction, and their actual time in the OR is limited, and so we may not have the opportunity to actively rewarm if they become chilly. So those folks are at a bit of a disadvantage, and we'll talk more about that later. So as we know, SCIP INF 10 was topped out in 2014. But we are seeing, with the shift of our cases to the ASCs now, monitoring and reporting requirements with financial penalties. So I think that's really important and helps us moving forward. This slide represents a 2015 study that was done at the Cleveland Clinic. The study included 58,000 surgical patients, and it revealed that despite the use of forced air warming, 64% of the patients were hypothermic 45 minutes after induction. So this again plays into my original comment about the prevalence. We're still actually seeing a lot of these patients becoming hypothermic. The study goes on to say that even in actively warm patients, hypothermia is routine during the first hour of anesthesia. And then they conclude that although the average core temperatures progressively increase after that first hour of anesthesia, intra-op hypothermia was common and it's often prolonged. They also say that hypothermia was associated in this study with this risk of transfusion requirement, and they say that this is consistent with numerous randomized trials that are out there. So even though we have the ability to rewarm these patients if they become hypothermic, this gives us an indication that it may not mitigate the complications that are triggered by hypothermia. So again, another example of how the challenge continues. So shifting a little bit to the notion of, again, what can we do in a situation like this? In an article that was published actually back in 2010, entitled Keeping Patients Warm Throughout Surgery by CRNA Sherry Burns, it stated that the secret to making sure your patients stay warm is to combine measures to maintain body temp from the time the patients enter your facility through discharge. So again, 2010, this notion has been around for a while. And the article goes on to really share with us that when we assess the risk for development of unplanned hypothermia, we need to remember that all patients are at risk and they need to be protected. We should really challenge our historical protocols. One method alone may not be working, so that's a one-size-fits-all type of approach. Or many of us may be combining measures such as active warming and bath blankets, but we'll talk later in the presentation about why that may not be the most effective way to go. Instead, we need to evaluate our population and come up with the best combination of methods. So now we're going to take a little bit deeper dive into the patient's peri-op journey and just talk about the various areas and what might be some opportunities for us to improve or enhance that experience. So in this slide, I'd like to expand a little bit on the notion that every minute counts. Unintended or inadvertent hypothermia has been called the most frequent preventable complication of surgery with all patients at risk, regardless of their age, gender, or the length of the surgery. Evidence-based studies demonstrate that most of the patients arrive at our pre-op area normothermic, yet we're missing opportunities to prevent cutaneous heat loss. So in this slide, the upper half, essentially shows, and the lower half, that our patients arrive normothermic at our facility. But in the upper portion of the slide, if we're not implementing any interventions to pre-warm or prevent them from losing that cutaneous heat loss, as they go into pre-op and we conduct a number of things that are really necessary in that area, and then we transport them to the operating room, and then the effects of the OR itself, we can see that by the time we get to induction, those patients have already started a downward trend. Whereas if we take them at a normothermic state on admission and take actions to keep them warm before they get to that point of induction, we have a much greater opportunity to maintain their temperature throughout their procedure. So this slide I've identified as missed opportunities, and it comes, you see a lot of bits and pieces of this information in various articles and guidelines, etc. But I divided it into 4 areas that I see as being missed opportunities: the admission or waiting area, and pre-op, and then transport in the OR suite. So starting from the very beginning with the admitting area or the waiting area, my observation has been that in the summertime, the air conditioning is just cranked to the max and it's freezing cold in that waiting area. Then in the wintertime, we may have heat going, but the heat may not be sufficient. Or if you're in a climate where you have warm temperatures year round, that admission and waiting area can always be just a freezing place to be. So even though our patients may arrive normothermic, they're in this waiting area, and whether it's 15 minutes or if we have delays because of a case running behind or whatever, the patients can be in there for extended period of time. So before they even come into our pre-op area, they're starting to trend downward in their body temperature. So then we take them back to pre-op, and understandably, there are so many things that have to be done before the patient goes back to the OR. It's a very fast-paced environment, and the nurses work very hard in here to get everything ready for these patients to go back. But we undress them and put a very thin patient gown on them. Often the temperatures in the pre-op area are chilly as well. They may not be quite as bad as the waiting area, but it's not uncommon to have it be quite cool there. Then we're starting lines, whether it's the IV or other types of lines. And we're starting most often with room temperature IV fluids. But the issue with that is if we have a room temperature IV that may be 68 to 70, 72 degrees in that room, well, that's a good 20 to 25 degrees below the patient's core temperature. So that's contributing to cooling them down. Then the various preparations that have to take place. We mark the surgical site, and every time we access the patient to do one thing or the other, we're pulling back blankets, covers, releasing cutaneous heat, and that contributes to that downward trend. Then when we transport them, that's a whole different mechanism, but we have a draft. It's that convection. We've got the cool air going around them, and whether you have a smaller peri-op area or if you've got a large facility with 45 plus ORs, it can be quite a trek to get to that facility, and the draft of that transportation contributes to lowering their temperature. Also, depending on the design of the OR, many times now you can see pre-op on one floor and the OR area on a different floor. So that adds to the delay, and it's an elevator ride as well to get up to the operating room. And then when we get into the OR itself, we know that those rooms are very, very cold. And with everything that we have to do to get them ready for surgery, they just have multiple exposures for prepping and positioning and all of that sort of thing. If we have a shorter procedure, these folks often go through the similar process to get to that point, but it's not possible to regain their temperature balance before we take them to the PACU, and then that often requires additional warming interventions and nursing time, and perhaps even longer lengths of time in the PACU for recovery. So for this reason, we really have to strive to maintain the patient's body temp by minimizing the cutaneous heat loss to maintain normal thermia for the patients. So shifting gear just a little bit now, most of you I'm sure are familiar with Enhanced Recovery After Surgery, or ERAS. These programs have been shown to have a positive impact on patient outcomes. The ERAS care system includes an evidence-based guideline, an implementation program, and then an interactive audit system to support practice change, and they're always updating, tweaking, improving this process depending on what their findings and outcomes are. The key elements of the ERAS protocols include pre-op counseling, optimization of nutrition, and so we're often with these protocols not seeing that NPO at midnight any longer. They're wanting to prevent hypoglycemia. So they move that mark up a little closer to the OR time so that they've got some nutrition on board. They standardize analgesic and anesthetic regimens, and also implement early mobilization for the patients. So with the analgesic regimens, they're looking also at minimizing that post-op pain, which taps into our opioid crisis, and just really a smoother and more comfortable recovery for the patients. The ERAS Society has its roots in what's called the ERAS Study Group that was developed back in 2001. It was comprised of leading surgical groups from the UK, Sweden, Denmark, Norway, and the Netherlands. And as you can see from this slide, the society has developed protocols for quite a few different types of procedures, and they're active and busy. These protocols have spread to other countries. They've come to the US for sure. And so the guidelines are divided into sections: pre-op, intra-op, and post-op phases. So in this slide, you'll notice that preventing intraoperative hypothermia is addressed in all of the guidelines. If you look, just Google or go to their website and pull up these guidelines under the anesthesia section, you will see in every one pre-warming preoperatively and active warming intraoperatively. And so the program really takes warming our patients very seriously. They consider patient warming to maintain perioperative normal thermia to be a key component in accelerating patient recovery. So not just, good outcomes or whatever, they truly believe that normal thermia accelerates the recovery. And so we all want that for our patients. Over the past several years, as I mentioned, we're seeing facilities develop similar guidelines that use a multimodal, multidisciplinary approach. And this evidence-based medicine is used to define best practices during the peri-op period. So since patient warming, again, is a key component to accelerate the recovery for our patients, we really need to better understand how to implement strategies to effectively prevent cutaneous heat loss. So focusing a little bit on our more familiar guidelines, AORN and ASPAN really echo each other in very similar ways. The 2015 guideline for prevention of unplanned hypothermia for AORN states that the majority of evidence establishes the benefit of pre-op patient warming. And so this is really important for us to adopt this. Often we don't see this as we're out and about. but it's important for a number of reasons. Patient comfort is very important. We want them to experience, to the extent that they can, a comfortable environment, and preoperatively having the temperature right, having them warm really helps them as they step into, taking their journey through the operating room. Also, pre-warming helps to effectively bank the heat. And what I mean by banking the heat is that, my goal would be to send the patients back to the operating room so that when they are induced, that they're actually as warm or perhaps even a little warmer than they were when they came into our department. By doing that, you've got nice warm peripheral blood in the arms and legs, and we don't see quite the difference in the variance in those temperatures when we have that, peripheral to core shift. And so keeping them warmer gives them a better shot of maintaining normal thermia as well. Then if we look at ASPAN's guidelines as well, they recommend implementing passive thermal care measures, and they call for us to do that preoperatively. They define it as warm cotton blankets, reflective blankets, socks, and head coverings, and they point out that we should limit skin exposure to lower ambient room temperatures. The guideline goes on to suggest that you continue these measures perioperatively, and they call out again that we need to limit skin surface exposure, and then to implement active warming in addition to passive thermal care when necessary. So what we have here is, 3 organizations all really on the same page when it comes to warming, all saying that we need to pre-warm. And I think this is one big step that we can take that will help our patients as they step into that peri-op journey. I present this slide really just to show you the benefits of the pre-warming, and this is with reflective warming products. The study was done in 2010 by a CRNA by the name of Leo Leleveld, and it demonstrates the benefit of pre-warming benefits with reflective gowns. The patients in the intervention group successfully maintained normal thermia, while the control group patients experienced significant decline in their temperature, and more than half of them required active warming to reestablish normal thermia. So if we can maintain the patient's temperature throughout their experience, it's far more beneficial for their experience than to have a hypothermic event happen and to have to implement more aggressive measures to warm them up. I think most people now are probably familiar with the mechanisms of heat loss. These are, evidence throughout, but the largest sources are the radiation and convection. It's important to know, though, that both of these occur more rapidly when the skin surface is unprotected. And so what do we mean by protected? Or what are we doing that does not provide protection? I know often the perception is that when a patient's covered by a bath blanket, for example, that protects them from heat loss, or when we're covered with surgical drapes, that's protection, but it's really not. Those things do not hold in cutaneous heat for our patients. So once the patient moves into the intra-op area, it's imperative that we protect the patient there as well by maximizing skin surface coverage to prevent the heat loss. The reason this all is important, and this is a statement that really ties into my mentioning cutaneous heat loss, according to the Cleveland Clinic Center for Continuing Education, roughly 90% of metabolic heat is lost through the skin surface. So often comments that I hear in my travels is that, oh, we'll cover the head because we all know that we lose a lot of heat from our head. And that's true. It's a true statement. But as you'll see in just a minute here, we actually have the opportunity to lose a significant amount of that heat everywhere. So you do not have this slide. I added this last minute, but I just wanted to summarize the patient's journey from the time they come into our admitting area until they arrive in the OR. And essentially what you can see is that with room temperatures being cold pretty much consistently throughout that journey. They have multiple exposures, all necessary things. We're prepping them, doing all the things that are important for them to go back to the OR, and then we have to do that transport, of course. But you can see collectively, cold temperatures, multiple exposures. We don't have the opportunity for patients, if we're not protecting them, it's no wonder that they're cold by the time they even arrive to the operating room itself. And I see this really as a perfect storm for hypothermia for our patients. So in the next slide, we're going to look at how perhaps we can start to address that. Many of you may be familiar with the rule of nines. It divides the body surface into sections, each with a value relative to the total body surface area. And I like to hold this out for nurses in the pre-op area, whether it's doing all of these things you have to get the patient ready, or when you go back to the operating room. Because if you look at this diagram visually, look at where your incision and your prep area is going to be, and then our goal really should be to cover every remaining square inch of this patient's body to the extent humanly possible, because you can see the opportunity for cutaneous heat loss. It's not just the head. The updated AORN guideline gives us considerations for selecting a warming method, and they tell us to look at the planned procedure, as I just mentioned, look at the position that the patient's going to be in, and then look at warming equipment constraints, because some of the equipment, and depending on where we're working, it really can limit the access to the surgical site. So combining methods, which I'm going to give you an example now, we're going to walk through that, such as passive and active warming, it can really significantly improve the skin surface coverage. So I've chosen lithotomy procedure. We know that that's a familiar procedure for GYN and urology, but we're seeing it being used more and more for robotics. So I think that's a good example. And look at the legs. For example, in lithotomy, we've got both legs up in those stirrups, and each leg accounts for 18% front and back. So both legs up in stirrups, we're looking at 36% of the cutaneous heat that can be lost right there, and just having those under a drape does not prevent that cutaneous heat. So typically what I see is we'll have an upper body active blanket on the patient, and that's great. That's a great start. That blanket will cover approximately 27% though of the patient's skin surface if it covers the chest, maybe a smidge of the upper abdomen and the arms. But if we add a passive modality like a reflective warming cap or a lower body blanket for the legs, put one around each leg, or you can put reflective leggings on that patient to cover an additional 45% of the skin surface, now we're really making some progress with that. Combining these two measures together, it maximizes our skin surface coverage to 72% and reduces our exposure to only 28%. So that's significant by just adding that one little step to the process. And we have to remember, going back to our very, very cold operating rooms, those extremities are pumping cold blood, room temperature blood, if you will, back into the core throughout the procedure, and it's really defeating, our efforts to try to maintain that patient's temperature. So if we can prevent those legs and prevent that cutaneous heat loss, I think that would make a significant stride in the right direction to maintain their temperature. Once we go into the PACU, we know that the team is responsible really for continued care, and that includes preserving the patient's heat and preparing them for discharge. But you can see that shivering, we all know shivering is common, and according to Bach and Mach, after general anesthesia, shivering is a common complication with both normothermic and hypothermic patients. Post-op shivering also increases the oxygen consumption at a really critical time, and so it can worsen the pain. So thinking about the shivering and how it increases pain, I'd like you to reflect back to these new ERAS protocols where they're really striving to minimize that postoperative pain piece. So we're actually kind of impacting that element of those guidelines as well. So in my mind, it just supports, reinforces the need to try to prevent that shivering. So if the patient's normothermic, I have a question though. Do we need to implement warming methods? It's common, it's not a criticism, but it's common when patients come into the PACU that we get them settled in, but then immediately the warm bath blankets go on. But if they're shivering and they're normothermic, really we need to get anesthesia involved, again, keeping in mind the increase in pain. So knowing that underlying cause is really important in how we manage that shivering. So what's at risk for our patients? And I think that we all understand, that hypothermia is bad. According to AORN's guideline, they say that hypothermia can cause multiple complications. Those can include adverse myocardial outcomes, altering the metabolism of anesthetics and other medications. And again, thinking about back to ERAS, how they're focusing on the metabolism and on anesthetics and analgesics. Affects thermal comfort, can increase the length of stay in the PACU, and also they talk about shivering in the guideline. So my intent is not to go into these complications here, but more to really bring them to your focus and hopefully keep these on the forefront of your mind for every patient that comes into your facility. Unfortunately, often we don't see these complications manifest in our department. Our patients move through our area, somewhat quickly in the peri-op journey, but if they develop, a post-op incision infection, or if they have a pressure ulcer that develops, unless they come back for a debridement, we're not necessarily aware that those complications even develop. So I just post these up here to really remind you that they're out of our sight, but these things are very real once that cascade is triggered with hypothermia. So let's shift gears a little bit. These common warming methods are not going to be new to you, but I'm hoping I can share a couple pieces that might be new to you and might be helpful as you make these decisions. So we all know that there are two forms of warming, active and passive. And looking at passive examples, cotton bath blankets, reflective warming, socks and head coverings. And then our active, just some examples are forced air warming, circulating air, and radiant warmers, for example. So cotton bath blankets are, they've been around since the beginning of times when it comes to the OR. We all love our cotton bath blankets, and we love to give those to our patients. It's kind of a nice comfort measure that we can provide them to have that warm blanket next to their skin. But I think we all know that they don't stay warm for very long. The average is about 6 to 8 minutes. And so we see a high level of utilization of bath blankets in the peri-op space. I can say from my experience, we see anywhere from 6 to 8 or 10 or 12 blankets used per patient. And it's important to know that there's a reprocessing cost associated with those blankets. So with an average of maybe 80 cents to $1 per bath blanket, you're adding for every procedure that comes through your facility, and added, $8 to $10 or $12 to that cost. And if you annualize that, it can be a pretty big number if you're a busy facility. Unfortunately, though, there's a bigger issue in our efforts to, warm or pre-warm with bath blankets, which aren't real effective as well because they're very loosely woven, so they don't protect or hold in cutaneous heat. They're also a linting item, and so they may be contributing to a bigger issue in our operating rooms. According to Moss et al., sterile lint and fibers in the OR serve as a transport mechanism for opportunistic bacteria, which can potentially be carried into the air currents and settle into our open wounds, onto the sterile fields, instrumentation, and into areas where subsequent re-aerosolization can occur. And so how long do those fibers with attached contaminants hang out in our operating room? You know, that's a good question. When these are deposited inside of the surgical wound, the particles can really adversely affect the healing process and lead to more serious complications for the patients. Again, something that arises outside of our area of operation, so we may not even be aware when these things are happening. The author goes on to state that removing lint in the OR is imperative in today's healthcare environment. So again, even though we really like our warm bath blankets, I'd really encourage everyone to get your hands on this information. Just Google sterile lint and fibers in the OR. What's the big deal? And you'll be able to see all the complications associated with that. So another passive method, reflective warming, and we use those just like you would linen. So they come in the form of blankets, gowns, or caps, head coverings. But the difference is that they have intrinsic warming and insulating properties. So they start to work as soon as you put them on the patient. And they're a great adjunct to active warming. So the two can be used, like I gave you the example in the lithotomy position. They work very well together and really help you to maximize that skin coverage. Getting on to the active measures, active warming, I'll just touch on that because I know it's one of the most common modalities or interventions that we see in the OR today. And according to Roth, though, it's difficult to demonstrate an increase in core temperature from our active warming techniques until at least 30 minutes have elapsed. And so getting back to my ambulatory surgery information, those shorter procedures, most of these patients, again, go through that same pre-op experience prior to getting to induction and incision time. So we need to keep in mind that we need to really protect these patients. It's very, very important. And then lastly, when we use a upper body or a lower body blanket, well, we have a whole lot of the patient's body that's still at risk for cutaneous heat loss. This is an example of a study that was done at the University of Tennessee Medical Center in 2015. It was conducted by Eddie Patterson and Robert Heidel, and it compared active and reflective warming methods for their patients there. And what they found was that each intervention to maintain normal thermia was proven to be equally effective in preventing hypothermia. So again, just reinforcing that the combination of methods here can work very well. And again, it's supportive of the recommendations by AORN and ASPAN. So again, we ask the question, what can we do as nurses? I truly believe that nurses still are influencers in our care settings. And I really think it's important that we try to look at this as a common goal, that we work together in all phases, pre-op, intra-op, PACU. We really need to pull our anesthesia teams and surgeons into the conversation so that we're all on the same page. I see these 4 areas: room temperature, warming our IV fluids, having a focus on preventing heat loss, and then a combination of warming modalities as being our 4 areas that we can really have an impact. With the room temperature, I know that it starts in the waiting area. We don't, again, we're not really exposed there, but our patients are experiencing time there. I know that there are real challenges with surgeon and staff preferences. When they're scrubbed in, it can get really warm, and I know those challenges are real. Yet we're starting to see surgeons around the country who are stepping out and saying, you know, these complications are not worth, you know, jeopardizing the outcome of my work, the outcome for my patient. And so they're actually taking measures to increase the room temperature to be a minimum of 68 degrees, but preferably some of them even adjust them up a little bit warmer so that they know that their patients have a good shot at maintaining normal thermia throughout. In my travels, again, most facilities are doing an awesome job with irrigating fluids. They warm those for the OR, but it's not very often that I see warm IV fluids being started. And again, just to reinforce, if we're starting room temperature IVs, those are 20, 25 degrees minimally cooler than the core temperature for our patients. And so that is clearly adding to that downward trend of cooling for our patients. I've emphasized over and over again about how we can prevent cutaneous heat loss, and it really works in combination with all of these methods or all of these interventions, but cutaneous heat loss and having that goal is key for all areas of the patient's peri-op journey. It's very important in pre-op that we only expose the areas that we absolutely need to expose and keep them, wrapped up and tucked in snugly otherwise, so that we can keep them warm. Same in the OR, even though we're positioning prepping, try to really keep them wrapped up and covered to the very best extent that you can to prevent that cutaneous heat loss. We want them to go into induction having nice warm extremity blood. One last thing I want to share with you, this is just a side note that I'm sure you're all familiar with, but just a reminder that we need to be aware that tourniquets and sequential compression devices, that needs to trigger an alarm in our head that we need to be aware of the mechanism of action and how the cool rooms affect having a tourniquet or an SCD. The SCDs are giving a pumping action of that cold peripheral blood into the core, which can be really counterintuitive, and it really works against our efforts to keep the patient's core warm. And if we have a cold room, that's that cold fluid or blood being delivered to the core. With tourniquets as well, release time is always, we record that, we're always aware of that, but we just need to be aware that that's another big case for having those rooms warmer, because there are known complications that occur from that cold blast of peripheral blood hitting the heart and causing cardiac complications. So just a little reminder there. So in summary, I ask, what role will you play in this process? The shift to ambulatory surgery will continue to be our future, and I think it's not a bad thing, it can be a good thing, but it's important to remember that all patients are at risk. So regardless of whether we're having to report on these folks or not, those shorter procedures really count and they matter. In spite of our efforts with hypothermia prevention, experts agree that it continues to be a significant issue for our patients. And so we've been talking about it for a long time. We've had a lot of measures that we've implemented to measure quality and that sort of thing, but it's still happening, and it's happening a lot. So we need to heighten our awareness and see what we can do to try to offset that. The ERAS program considers patient warming to maintain perioperative normal thermia to be a key component in accelerating patient recovery. So another reason, another motivation for us to want to accelerate our patients' recovery. That's what we'd like to see for them. Maximum coverage of the skin at all times is essential to minimize cutaneous heat loss, pre-op, intra-op, and in the PACU. Hypothermia is a serious issue. We may not see the effects in our department, but once that physiologic cascade has been triggered, our patients are at greater risk. And then aggressive measures to rewarm the patients have to be implemented, and it's catch-up from that point. And I don't think that playing catch-up is where any of us want to be, and it's not where we want our patients to be. And finally, using the combination of methods from start to finish is the best strategy to really prevent cutaneous heat loss and to keep our patients warm from start to finish, because every minute really counts in the operating room. So with that said, that concludes our presentation. Thank you all for your patience and listening. And I think I'm going to turn this back over to Linda now to see if we have any questions.
Okay, yes, thank you so much, Angie. I've got a couple of questions. What is the biggest challenge that someone will face with maintaining normothermia?
Well, in my travels, as I call it, I really see that there is often the warming element. We think of it as an OR issue. We know that the OR rooms can be really cold, but I think the challenge might be just the communication amongst all of the departments. I think having the ability to have that common goal in the waiting area, in pre-op, as well as in the OR, and then when they go on to PACU, I think that can be a challenge. I don't know that everyone is so busy, you know, we need to be able to have those conversations of how that journey from start to finish really, really impacts the patient's experience and their temperature.
Okay, that's great. What are some creative measures that you can use to keep your patients warm?
Well, I think that creative measures, I've laid those out in the presentation. The key is combination of measures, but we also want to be sure that, you know, what we're using is really effective. And I know that I've given the example, we see so often active warming blankets used in combination with warm bath blankets, but because of you know, the weave of those blankets and the fact that they do not stay warm, you know, it's not necessarily effective. So one thing that's important is to be sure that with the methods that we use, that we're following the instructions for use with those items, so we're sure that we're using them properly, but that also that we're using those methods and combinations of methods that are really effective.
Okay, that's great. I've actually got two questions about the same subject here. It's what type of thermometers do you recommend?
Oh boy, that's $1 million question, because I think if I go back to the AORN guideline, which I have to, I worked there for a little bit, and you know, I think that the most important point with measuring temperature is that they call for that consistent method of measuring from start to finish, because you know, it's very common that we see different modalities used, and a lot's dependent on the type of procedure too, but rarely do we see the same method used from start to finish. I think some facilities are going in that direction, but the main point in my understanding and what I read is that it needs to be a consistent measure of monitoring. That really is the important goal, and focused. If you're able to ascertain, link that to a core temperature, that's even better.
Okay, thank you, that's great. I think we've got time for one more question. Is there any available data on pediatric warming?
No updates that I'm aware of. If that individual would like to email me, I know that AORN had I'm not recalling the issue, but in their journal they had a article on pediatric warming. You know, my sense for pediatric warming is that, you know, the little ones I think are at great risk for hypothermia, because it just takes such a slight variance in their temperature to impact them. But a lot of the recommendations are very similar as well. So preventing that heat loss, protecting them at all times. But if the individual would like to shoot me an email, I'd be happy to get the issue and share that information with them.
Okay, that's great. And just a reminder, attendees, Angie is quite happy to answer questions offline. So if, as you can see from her last slide, that is her email address. So please feel free to email. Thank you again for a great and informative webinar, Angie, and thanks again to our sponsor, Encompass Group. Just a reminder that one lucky attendee will win an Amazon gift card for completing the post-webinar survey, which will appear on your screen shortly. For more information on our upcoming OR Today webinars, please visit our website, ortoday.com/webinars. Once again, thank you again for attending today and hope you enjoy the rest of your day.
Thank you, everyone.